My name is Bruce Stevenson. I'm the guy on the right there. And with Linda Piccinini, we are Today's Dental Consulting. And what I would like to do is to go through some of the procedure codes that we see commonly overlooked by offices or misused by offices. And maybe have a brief discussion about some of these things with the objective of increasing both your production and your collections, but also increasing the ease with which you collect the money from insurance companies. If you go to our website, which is todaysdentalconsulting.com/codes 2018, not only is this video on there, but also a download of the individual slides I made to create the video. And those are in PDF format. The idea is you can kind of listen to the video, but not have to take any notes because the notes are already on the slides. So you can refer back to the slides to get procedure codes and so forth. So let me explain the format that I used here in presenting this information. If you look at the adult pro fee there, you see there's three fees over on the right-hand side, 133, 57, and 73. And these come from three different fee schedules. Up at the top on the right, you can see a UCR fee schedule, which is kind of a composite UCR fee schedule that I see from several different offices. The second fee schedule is a major PPO organization, a very large PPO dental insurance organization, and you would know their name, you would recognize their name if I said it, which I'm not going to do. And the third fee schedule is a smaller PPO, but I'm put it in because they cover a lot of things that even the major PPO doesn't cover, and to kind of give you an idea of what other PPOs are allowing for some of these procedures that we talk about. So just to kind of orient you there, the UCR fee for the pro fee is $133. The fee schedule of the major PPO provider is only $57. And the third fee schedule over there from a smaller PPO, but still a PPO fee, is $73. Now, if you look at the difference between the $73 and the $133, I'm sure you're all aware of this already, that's a big cut in your fees. And so one of the things that I suggest you might pay attention to is how can you increase your production with allowable procedures that maybe you're overlooking. Here's an example of something that a lot of offices do, and that's use nitrous. And great, and you can see that there actually are fees in there for nitrous. Now, in the good old days, we often would give this away. Nowadays, you may not be able to afford to do that, and a lot of the PPOs are covering this. But whether they cover it or not, I think offices are kind of in the habit of telling patients this may not be covered by your insurance. So do you still want to use the nitrous? And most of the time, the patient, of course, will say yes. So keep that little phrase in mind. This may not be covered by your insurance, because I think we need to use this more with patients and more with different procedures. So that's one of my themes going through here. This is a relatively new procedure code in here, and now it's beginning to get paid. And this is the Caries risk assessment. So there's three different codes for 3 degrees of risk. The first one is a slight risk, the second one, the 602, is a moderate risk, and the third one, 603, is a severe risk or high risk. And if you look over there, you can see that this is getting reimbursed by the big PPO at $6 when you do it, and $33 by the smaller PPO. So if let's use the third PPO there, the third column, as an example, I think they paid $73 for a pro fee. This will add another $33 onto that pro fee that may get reimbursed if it's properly documented. So how do you document it? Well, here's a form from the ADA. They have two forms, one for 6 years old and above, and another one for less than 6 years old. And it's a little check-off form that you can do. In the case of Open Dental, we created a sheet in there, so you can just check these things off in a sheet. You have a copy in the chart, you can print it and give it to the patient. So this is great PR for the patient. It's also very good as far as preventative care, and you may get reimbursed, depending upon the PPO contract, something for your trouble. And this can be done by a hygienist. This doesn't have to be done by a dentist. So pay attention to those codes and to this form. What else we got? Now, speaking of prevention, let's talk about fluoride. So there's fluoride varnish, and then there's the other fluoride code, the 1208, which is typically the fluoride in the trays, although it says technically it's all other forms of fluoride. But usually that's what people use when they're doing the fluoride in the tray. I want you to notice that the fee up here in the upper right for that smaller PPO, the fee for the fluoride varnish is actually greater than for the fluoride in the tray. And this is fairly common, as a matter of fact. If you look at the large PPO, it's the same fee. But those two fees, the fluoride varnish is either the same or higher than the fluoride in the tray. Now, the cost for in your office for doing fluoride varnish, I just noticed this misspelled up there. Oh well, for doing fluoride varnish is actually a lot less. It costs you about $1, and the time involved is certainly a lot less than 4 minutes of fluoride in a tray. Patient acceptance is also much better for fluoride varnish because it's much less invasive. So there's a lot of good reasons to use fluoride varnish rather than fluoride in the tray. And the last big reason is it's more effective. So if you're doing fluoride in the trays, maybe you need to get a little bit more modern thinking there. I suggest that you don't do that. And if you are doing fluoride varnish, make sure you use the correct code, because quite often you'll be reimbursed more. So let's have that go away. So this is another example of talking to patients about what may not be covered by their insurance. So if you look there, superimposed on that previous slide are some progress notes which were generated automatically, in this case in Open Dental. In other words, but you can do it with other software too. In other words, the procedure note is tied automatically to the procedure. So when I post topical fluoride application with varnish, automatically it puts that code in there, and you'll notice it says that we discussed it with the patient and let them know that their insurance may not cover it. So if the insurance, of course we want to bill the insurance, but if the insurance doesn't pay, don't write it off. And a lot of offices do, and I think that's a mistake. Particularly when you bill this with the Caries risk assessment to document the need for fluoride varnish. It often will be covered, almost always for kids, but often it will be covered for adults too. You notice the Caries risk assessment, the second line there, has a note automatically associated with that. And then down clear at the bottom, where it said patient declined fluoride varnish, I think you should have the discussion with your patient about whether or not, adults I'm talking about, whether or not they want to use fluoride varnish. If they say no, here's a quick way to chart it. You have a procedure which you have to create on your own. There isn't an ADA code for it that said patient declined the fluoride varnish. And it puts that note in there automatically. So I think the hygienist should be having this discussion with virtually every adult patient. Now, if you've got somebody that's 30 years old, never had an interproximal carious lesion, okay, they may not benefit from the fluoride varnish, but pretty much everybody else will. So I think having this discussion is just good patient care. And also when you bill, if you bill for the fluoride varnish and the Caries risk assessment, you may increase the likelihood that you're going to get paid by the insurance for those two items. Again, increases the value of that prophy appointment with really very little work. Here's a couple other things. It seems to be a lot of misunderstanding about which codes to use for what procedures. You know, we've had a code around for doing a culture and sensitivity for an infection. And there is one code for collecting the specimen, which is typically what the dentist would do. So a patient has an infection, you're not sure what organism is involved. We don't do this procedure very often, but physicians do it. So you culture it, send it off to the lab, and they tell you what bacteria are growing and what they're sensitive to. There's other procedures here. So in other words, you had a fee for collecting that specimen. There's other fees that you can have, other procedure codes for collecting other types of specimens, including the DNA in saliva tests. So here, this is for perio, but more and more we're seeing these other types of tests being used in offices, and you can get reimbursed for it. Okay, so if we look at the top one up there, the collection for generic testing, we can see that better PPO plan, not the large one, but the smaller one, will pay you $50 just for collecting that. Now, the analysis of the sample is a different fee, and that could be charged by the lab. In the case of the DNA stuff, it's typically charged by the office, and then the lab is paid by the office. But there's a different fee for that, so don't just charge one fee if you're going to do something like this. Another thing that's not done very much, but is reimbursable from some of the plans, is some sort of Caries susceptibility test. And basically you're either growing it in a culture or you're doing kind of a fancy litmus paper. If you do these procedures, great. Don't forget, there is a procedure code in there for it. How about clinical photographs? You know, you can get reimbursed for doing clinical photographs. And I frankly, and this is an extraoral camera, but it's used to take intraoral photographs. However, if you have an intraoral camera, same code applies, and you can get reimbursed for doing this. So I think these kinds of, I love the camera, the clinical camera, rather than the intraoral camera, for showing patients what's really going on in their mouth and for documentation. This can be done by an assistant very quickly, 5 minutes, maybe less. And again, so you're going to get reimbursed for $29, $35 somewhere in that ballpark. And I think these ought to be done like every 5 years for every patient, during an initial exam and then about every 5 years afterwards, just to document what's going on in that patient's mouth. How about diagnostic casts? Yeah, you probably knew that you could get paid for diagnostic casts. A lot of people still don't do them, and sometimes people do them and don't bill for them, but you should bill for them because you're going to get reimbursed. The other thing is iTero and some of the other intraoral camera people are pushing doing a periodic scan so you can see changes in the patient's mouth. Okay, I don't know how concerned I am about using a scan for something like that, but you could, and if you do, great. Be sure that you charge for it, and that's a type of diagnostic cast. So that's the code that you would use. How about occlusal sealants? Offices tend to fall into one of two categories. Either they do sealants or they don't. And if they don't, I mean they really don't. You never see a sealant on their day sheet. And one of the reasons is because the hygienists are the ones often that are going to do the sealants, and they're difficult to do alone. It takes really an assistant to do an effective resin sealant. However, there are now a lot of glass ionomer sealants, and it's something that maybe you want to look at because these are more easily done by a single operator. And they're more resistant to moisture contamination. So kind of something to think about. Now, some people have said in some studies that these are actually more effective because they release the fluoride than the resin sealants are. The retention certainly isn't as good, but the fact that they release fluoride, and they also tend to stick down in the little fissures pretty well. So they may be actually more effective at preventing caries than resin, but certainly it's something to think about when you have trouble isolating, and especially when you only have one operator. Another thing, probably general dentists should do more stainless steel crowns on deciduous teeth. But if you're doing stainless steel crowns, be aware now that the insurance carriers will cover more sometimes for an aesthetic crown. In other words, it's white. So it's still a stainless steel crown, but it's referred to as an aesthetically coated stainless steel crown. And they have these both for deciduous molars and certainly for anterior teeth. And if you're doing these, make sure you use the right code because you may get paid a little bit more. How about this? Not too uncommon to have to create a crown, fabricate a crown, to fit an existing partial denture. And the lab is certainly going to charge you more if you're using a lab. Well, now there's an official fee in there, a procedure code, so that you can charge the patient and the insurance company an increased fee if you have to make a crown fit an existing partial. And particularly if you're using a CERAC, this is a great use for a CERAC because you can use the correlation to create that crown. So you scan ahead of time and then make the new crown look just like the old one, and then all this should fit. Don't forget, if you're using the CERAC in this situation, to charge this fee. This is another one of my pet peeves a lot of people don't know about, and that is all porcelain crowns typically get paid at a higher rate than porcelain to metal crowns. And yet typically the lab bill for an all porcelain crown is less than the lab bill for a porcelain to metal crown. So, okay, just kind of might take that under advisement. That doesn't matter whether the material, as long as it's all porcelain. So it can be Bruxer or it can be the Emax. So again, with the CERAC, generally people are using the right code and getting reimbursed a little bit more. For people who aren't using the CERAC, maybe take a look at doing more all porcelain crowns. So here's two new, relatively new procedure codes, and this is scaling basically super prophies. And the first one, the 4355, is done before the exam is done, and the 4346 is done after an exam is done. So it's the timing that makes these things different. And if you look there, the 4346, which I think was new in 2017, but I'm not positive, but it's a relatively new code, and so far that's not getting reimbursed. I don't find either one of these used very much. I kind of put them in there for completeness, but understand the difference. One is used at an appointment prior to the exam appointment. The second one, the 4346, can be done at the exam appointment, but the 4345 cannot be done at the exam appointment. So just kind of, if you're going to use those codes, understand them and use them correctly. They probably are not going to get reimbursed. You're probably going to get downgraded just to a prophy. How about root planing and perio maintenance? The key here is documentation. Lots of claims get denied because of inappropriate or lack of adequate documentation. Okay, you know that you have to send pocket markings. Okay, now one of the nice things in Open Dental now in the latest version it's included is you can do voice charting. It's free. It's included in Open Dental, and you can chart bleeding and suppuration. It understands those words. So just by speaking in there, a hygienist by herself, again, single operator, can record all the appropriate periodontal information. So that's kind of nice. The other thing is, in addition, because we want to give the insurance companies as much information as we can when we bill for these things. And we've got, you may not submit, if you're doing it electronically, particularly with a two-way e-claim service like Claims Connect, you're probably going to submit the claim without any documentation and wait until they say, hey, send me, which they'll do in about 10 minutes, send me such and such, perio, pocket markings, x-rays, whatever. So you wait to see what information they really want, and you're not submitting things unnecessarily. Anyway, that's if you're using something like Claims Connect. If you're using one of the other e-claim services, or God forbid you're sending them on paper, you probably should submit as much information as you can with the initial submission, because you're more likely to get paid. Okay, so we talked about doing the perio pocket markings. Probably be a good idea to put 4 bite wings in there, and also to have good charting that includes the periodontal diagnosis. So with Open Dental, they have these auto note feature, which prompts the hygienist, in this case the hygienist, that's completing the procedure. And one of the prompts that you can put in there is the perio diagnosis. So you got your different perio types down there, and just click on the one that you want. And now that's present in the chart forever and ever. So if somebody wants to come back later to bill and needs the documentation, it's right there. This is just good charting, but it's also good documentation for getting reimbursed by the insurance company. Here's another procedure that is misunderstood, I think, and that is a surgical extraction of a tooth, which typically you get paid for, reimbursed for, at a much higher rate. People think if they lay a flap, that's a surgical extraction. No, the flap has nothing to do with it. A surgical extraction means either you removed bone or you sectioned the tooth, or both. Okay, so if you sectioned a molar to take it out, make sure you chart that, and again using the auto notes feature, so you document this in the chart and you will get reimbursed for that. How about a single rooted tooth? Can you section the root of a single rooted tooth? Now, I haven't seen this tried by an insurance company, but if you're doing implants, especially immediate implants, you know that sometimes you'll go down and section a single rooted tooth so you can elevate out the fragments without destroying the socket. So I would maintain that yes, you could do a surgical extraction on a single rooted tooth and section that root. But I have not seen that tested, let me put that way. The other thing is brush biopsies, like oral CDX. You can get reimbursed, not too bad, $115 or $70 for just doing basically a little swab and sending it into the lab. So again, there's a different code to read that slide, to do the histology. This is simply the collection of that specimen. So keep that straight. But again, if you're doing this, make sure you use the appropriate code for the collection. This is another code it's been around for 2 or 3 years, but a lot of people don't know about it. And that is if you section a bridge because you're going to extract one of the abutments, there's a code now for it. So you don't have to do this for free. So just kind of make sure you use that appropriate code. So here's another relatively new code that is for infiltration of resin into a small carious lesion, what they refer to as a non-cavitated lesion. And the ADA has come out as endorsing this type of treatment. So you may see this getting reimbursed more often. Right now, the major PPO is not doing it, but that smaller PPO will reimburse you for $78. This is the only product that I know referred to, this is called ICON, I-C-O-N, that allows you to do this. And basically what you do is desiccate the tooth, and then the resin gets sucked up by wick effect in there and then set. So it's a restoration, but it's a different way of restoring the tooth. So I think you're going to see more of this. This has been around for a couple of years, but I think you're going to see this increasing in popularity, and it's nice that you're getting reimbursed for this, at least by some of the PPOs. This is something that I will wholeheartedly recommend. I have nothing to do with this organization. I'm just a subscriber. This is Practice Booster, so it's practicebooster.com, and they have a newsletter, and they also have this online version. The newsletter comes out quarterly and well worth reading. Somebody in your office ought to read this newsletter. And then the online service is very nice because you can search for all the codes in there or by phrases that are part of the code. So there's lots of different ways you can search and find out all the little hints, kind of like what I did in this video, only much more extensive. So this is a really valuable resource, and I would highly recommend it. Whew. We're done at last. So that's the last slide, as you can probably tell. And if Linda or I can help you, just remember today's dental consulting. The only offices we work with are open dental offices, because we really do think in this day and age that your consultant needs to be intimately aware and very well versed in the practice management software that you use in your practice. And frankly, we just can't do it with other software, nor do we want to learn, because we don't think anything works as well as Open Dental does. So we only do Open Dental offices, but if you're either using Open Dental already, or if you're thinking about converting, why, by all means, get a hold of us either on our website, todaysdentalconsulting.com, or at the phone number. And again, if you want the slides from this presentation, it's todaysdentalconsulting.com/codes 2018. Okay, the end.